In dental schools, we learn an elaborate template of shape of access opening for each tooth. But in reality, we seldom see an experienced dentist using that template. Why is it so? That is because they use something called as anatomy-based access opening. What is this and what is the science behind access opening? So let me take you through the evidence-based approach of different types of access opening for each tooth so that you would be more aware and do better access openings. As we begin the anatomy-based access opening, on the day one, let's learn about a central incisor. So a central incisor is wider mesiodistally. If we open an axis which is wide mesiodistally, like a straight line, that makes good sense, but your rotary file will not fit because the width is not enough. So to make an enough width, we can make a buccolingual axis, that is a straight line buccolingually. Then you will be compromising on the cingulum. Cingulum is the part of the incisor which gives greatest strength. So once you damage the cingulum, then you're going to weaken the tooth inevitably. So how do we open an axis? That's when we do a triangular shape axis opening. This triangle shape is also the root canal cross section in the coronal part of the tooth. So you replicate the similar triangle shape of the inside canal space in the coronal part. Once we make the triangular shape, that gives us enough place for instrumentation further. And another thing that you commonly observe in central incisor access opening is that many people, especially the early stages of root canal treatment, face buccal perforation. That is, the file goes into the buccal space and the burr also perforates and access opening goes in the buccal direction. And you can see your file poking out of the gums. Why does that happen? That is because the incisor has a lingual shelf, that is a slight lingual extension from the cingulum area. So this lingual extension pushes or deflects your files into the buccal area. So that creates a lot of buccal perforations. So how do we prevent that buccal perforation and get a straight line access into the canal? That is by removing this lingual shoulder or the lingual shelf that is extending. That way we can get a straight line access and that prevents perforations. So is that triangular shape an ideal way of access opening? According to the recent research, Liu et al. In 2024 made a finite element analysis of different types of access openings in central incisors. And they have found that a conservative axis, that is a round shape axis, is ideal to give enough fracture resistance. But is this round shape axis good to do, and can all dentists do this round axis? It's a strict no, because if you don't have microscope or any kind of magnification, and if your irrigation protocol is not solid, that means if you are not activating your irrigant, if you're not maintaining enough time for the irrigant, then you're more likely than not to leave the pulp remnants in the root canal if you make constricted access openings. So strength of the tooth is important, but it is equally important to clean the entire root canal. So what can a dentist without magnification best do to preserve the strength of the tooth as well as clean the tooth properly? The only way here and the only thing that we can take from this study is that the cingulum is strongest area. So try to preserve as much as the cingulum width as possible. Try to make your access openings above the cingulum level. That will preserve the fracture strength of the tooth. And in that way, you can make a good access opening and instrument it well as visualize it properly, even if you don't have magnification. So the triangular shape access opening is ideal, but not for all teeth, because as the patient get older, the tooth ages and the root canal cross section turns oval So in older patients, you can skip the triangular axis and do an oval shape axis opening. And also, as the teeth attreat, in older patients, you can do an incisal axis opening. That means when you can see a red dot on the incisal edge, you can clearly go and start your axis near that red dot on the attreated tooth, and you can enlarge it, make it into an oval cavity so that your rotary files fit. So, yes, you can do conservative axis, but that is in very few cases. Try to include magnification so that you can make more constricted axis and activate your irrigants. Use lots of hypo so that your constricted axis openings will also lead to a successful root canal treatment.
We're done with axis opening. Now, when we enter the root area, the cross section changes to the round. So, to clean the canal properly, we should give brushing strokes with the file. And the apical foramen has an average size of about 0.30 mm. Uh, that means our master file should be of bigger sizes. That's at least like 0.5 or 0.6 sizes, unless it's a calcified canal. That way, we can clear the entire apical area. Mizutani et al. Have found that 17% of centrals have apical foramen coinciding with the root apex. That means in majority cases, apical foramen is usually displaced, mostly distolabially. What can we infer from that? If your GP is straight to the root apex in a radiograph, that means you've likely created an apical transportation of canal. So it is always advised to obturate the GP zero point 0.5 to 1 mm short of the radiographic apex. That way, you would not perforate and go beyond the apical foramen. Also, Kashera et al. Have done a study and they found that the central incisors has about 49% of lateral canals and 12% ramifications in the apex. And only 38.6% of the teeth had just one canal. What do we get from this? This means that when you pull the entire pulp out and feel great that the root canal is clean, it is still not clean and it is still likely to fail because in only 38% cases there is single canal. In the rest of the cases, you are leaving the pulp remnants in apical ramifications and lateral canals. So the best way to clean is by using irrigants like sodium hypochlorite and EDTA and activating it with sonic or ultrasonic devices. That way we can ensure that we have cleared the apical ramifications and the lateral canals, and we can at least give a little guarantee that our root canal is going to be successful.